So very good afternoon to everyone present here. Namaskar and warm greeting to all. On behalf of Strategic Institute for Public Health Education and Research, Sipher, in collaboration with Project Eco India and Resource Center for Tobacco Control at PGI Chandigarh, I extend heartfelt welcome to all of you, esteemed guests, speakers, colleagues, and participants for this important occasion to attend this important discussion and webinar. So today we observe a World Chronic Fatigue Syndrome Awareness Day. We gather here to raise awareness, foster understanding, and initiate much needed conversation around chronic fatigue syndrome, a complex, often misunderstood condition that significantly impact the quality of life of millions globally. The theme of our event today is Mind Over Fatigue, emphasize the interconnections of physical and psychological and behavioral demonstrations of this condition. It also bring into the focus how lifestyle factors such as tobacco use can interplay and chronic health condition in fatigue syndrome. So we are privileged to have with us distinguished panel of experts and through leaders in public health, psychiatry, and clinical medicine. So their insights today will help and bridge the gap, knowledge gap, and strengthen the public health responses to the conditions. So I thank each one of you taking the time to join us today, and let's us begin the proceeding for the day. So to start this event, I would like to invite Dr. Rakesh Gupta, President Sipher, who will briefly share insight about this theme and why awareness is essential in today's healthcare ecosystem. So over to you, Dr. Gupta.
Yeah. Rajeev, before that, I think we can have some snapshots of all
Okay,
the
sir.
participants.
So we
Yeah.
request all the participants to switch on your video for next 2 minutes for a screenshot. So all participants can switch on your video for next 2 minutes.
Can all please switch on their videos? Yeah, okay. I think most have switched on
Yes,
the
sir.
videos. Yeah.
Yeah, so we can proceed with next.
Yeah.
Yeah. So over to you, sir, for your.
So thank you, Rajeev. And as we all know that May 12, 25 is a International Myalgic Encephalomyelitis, or better known as chronic fatigue syndrome. It is an awareness day today. This day is dedicated to raising awareness about the ME/CFS and other chronic immunological and neurological diseases. They are called as CIND. And as we all know that most common symptoms are unexplained fatigue that is not relieved by the rest, post-exertional malaise, that is muscle, joint pain, headache, etc. Then the sleep may be not freshening, impaired short-term memory loss, and there's a decreased attention span. There's dizziness, nausea, vomiting, anxiety, and depression. They are the common symptoms. Symptoms are typically exacerbated by excessive physical activity or stress. Example, if you have an infection in the body. The physical examination is typically normal, and the treatment, there's no curative treatment. Management is focused on alleviating the symptoms, so it is symptomatic treatment only. There's a important correlation with the tobacco use, and the research suggests a correlation between tobacco use and myalgic encephalomyelitis or chronic fatigue syndrome. With some studies, they're showing a higher prevalence of tobacco sensitivity among individuals with CFS. So let us hear from experts. So we'll start from Dr. Rakesh Gupta. So Dr. Rakesh Gupta, he is president of the Rajasthan Cancer Foundation. He is a surgical oncologist and a WHO awardee. He's honorary consultant in tobacco cessation. Also, he is on experts committee of MOHFW and core committee of NOHPIM, that is National Oral Health Program for advancing tobacco cessation countrywide. He represented India in Asia Pacific network of quitlines. So thank you, Dr. Rakesh Gupta for joining. So let us listen to him.
Thank you, Dr. Rakesh, and greetings to all the participants on this day, which is very exciting in a way because we all admit that we don't know much about it, and we have to really be more focused on what is required to be done in such cases. And as Dr. Rakesh has suggested, as shown in his slides, that we do get symptoms many a times, and it's confusing hereafter that whether we are suffering from chronic fatigue syndrome or not. But I'll leave it to the expert, Dr. Abhishek Ghosh and Dr. Suneela to describe its details further. My task is to find out any correlation it has with tobacco use. I must also honestly admit that in last 30 years, I haven't really focused and known much about it. So my knowledge is more theoretical because I didn't even ask the patients who were coming to the tobacco cessation clinic as to what is their status in relation to the fatigue. But yes, the evidence is there that there is a distinct correlation between tobacco use and fatigue. Let me say also at the outset that not all the tobacco users suffer from chronic fatigue syndrome. Fatigue is an experience of being tired, lacking energy, and feeling exhausted. It is consistently related with the lifestyle as well as cognitive and physical impairment. So that's its definition in a way, a classic definition in a way. Now, despite its commonality, especially amongst many sufferers of the chronic ailments, the non-communicable disease patients, it remains frequently underdiagnosed, misdiagnosed, untreated, or mistreated, or I would say neglected because most of the healthcare workers are not very conversant with this. They are not aware of it. And if you're not really knowing about it, you won't even ask for the chronic fatigue syndrome in patients. So, although fatigue is a normal bodily response, severe or chronic fatigue should be considered an illness. That's one point that we need to make very clear. A clinically sickened fatigue is related to the greater risk of other health problems, and also it is associated with poor health behaviors, decreased physical activity, more complicated treatments, a lower quality of life. So all these are the sort of manifestations and outcomes that we see in the patients who are being managed otherwise for other ailments. Although smokers and vapers have been reported to suffer from chronic fatigue, tobacco users is largely missing. So that's one area of our study research that we need to do. Better we do it earlier. We have, despite the fact that we are the world's largest users of smokeless tobacco, the researchers have been missing in many areas of smokeless tobacco use. The users of e-cigarettes, they are mistakenly driven for its propagated lies for the use. They soon come to learn that due to chronic fatigue itself, they are falling deeper into its addiction. So it's a kind of vicious cycle which sets in, that you're fully feeling fatigued, and that's why you will vape more frequently because there is a fatigue. So it's a kind of getting into a situation of continuity. Now, the underlying mechanisms appears multifactorial. I think the main thing is nicotine deficiency. The tobacco use has been correlated with the transient feel-good experiences, such as alertness, better recall, energy enhancer, etc. All those who are working in tobacco control, they know that the nicotine is the cause for the reward and reinforcement experiences people have because of the secretion of dopamine in the brain, which acts in the precortical area to produce the cortical hormones and other pleasure producing substances. So these experiences appear earlier among the smokers versus the smokeless tobacco users, which I think is because of the delayed onset of action at the nicotine receptor sites in the brain. Once the nicotine crosses the blood-brain barrier, in smokers, it reaches within few seconds, it is about 8 to 10 seconds as compared to the users of smokeless tobacco users, where it takes a little more time, 15 to 20 seconds. So it's therefore natural to experience the fatigue as a withdrawal symptom in the absence, because when the nicotine is not there in the body or is deficient, when one is trying to quit, and if they don't understand it as to why it is happening, they will be perhaps facing it. Third reason is that's also due to the reduced oxygen carrying capacity in the blood in smokers. We know how the oxygen gets replaced by carbon monoxide among the smokers, and that may be causing the reduced oxygen carrying capacity in the blood. Also, as Dr. Suneela ji had mentioned earlier, it's due to the anemia which is caused by SLT use. There are studies that, yes, anemia is seen more in the pregnant women who are using the smokeless or chewable tobacco. So these are the three main mechanisms where we see that what can be the underlying mechanism. Cessation may reduce the intensity of suffering. However, the symptoms may persist for many months due to its partial recovery. Therefore, many tobacco users, this affection is barrier to quitting actually. The best bet is to stay away from it forever. But if someone you know is using the tobacco currently, help him or her to quit at the earliest through either brief advice or referral to a tobacco cessation center nearby or the National Quitline Services. A recommendation to use nicotine patch during the long COVID manifestation was made, but I think currently the evidence is at best unsubstantiated. So for me, the bottom line is that it's a distinct clinical entity that all stakeholders should be made aware of. Also, it should be detected early and managed while assisting the users for any type of tobacco or e-cigarettes in order to quit early to improve the overall quality of life through the enhanced capabilities, both physically and cognitively. I thank you very much for giving me this opportunity, Sipher and RCC teams, and I thank all the participants for your kind attention. Back to you, Dr. Rakesh.
Thank you, Dr. Rakesh Gupta. So it was actually enlightening for us to know that there is a correlation directly with the tobacco use. But surely not all tobacco users, they suffer from chronic fatigue syndrome. And neglecting symptoms as they're not conversant. Actually, healthcare workers, they are not conversant with the normal symptoms in the chronic fatigue syndrome. They normally don't diagnose it as CFS. The smokers, they have more chances, whether they are tobacco users or whether they are vapors. But the correlation with SLT is not known, right? So it may be due to nicotine deficiency, then it may be due to the oxygen deficiency. Oxygen carrying capacity is lowered in this case. So cessation is important in chronic fatigue syndrome. So we must always remember that it is a distinct clinical entity and should be diagnosed early, managed early, and the cessation is an important part of the management. So thank you, Dr. Rakesh Gupta. If you want to go somewhere, so please be present half an hour before.
I will stay on and I'll message you accordingly in the chat box when I'm leaving. Thank you.
Thank you.
Okay.
So now we have with us Dr. Abhishek. So he's a additional professor of psychiatry in PGIMER, and he has been a former consultant WHO Geneva in Vienna, and he has been honored with Tilak Venkoba Rao Orational Award, Bhagwat Award, GFBR Fellowship, WHO. So over to Dr. Abhishek. We'll listen to him about the. He's a psychiatrist himself, so and there's a direct link with the, the psychiatric, the mental health of the patient. So over to Dr. Abhishek. Dr. Abhishek, you have been made co-host, so you can please
sir.
share your presentation.
Thank you very much, everyone. And thanks to Dr. Gupta for your kind introduction. And thanks for inviting me here. And thanks to all of you who have made it to the webinar despite your schedule and also despite the holiday today.
Yes, it is visible. Yeah, it is visible.
I have made a few slides. This is our broad learning objectives. In the next 15 minutes, we'll try and learn what is chronic fatigue syndrome, what are the biopsychosocial underpinnings of chronic fatigue syndrome. There's more on the etiological part of it. What is the relation between chronic fatigue syndrome and other mental health disorders? And what are the psychobehavioral interventions? I'm not going to focus much on pharmacological interventions, but what are the psychobehavioral interventions of chronic fatigue syndrome? The definition of chronic fatigue syndrome, I have just underlined the important point. The first is it is chronic. Usually it is diagnosed when fatigue is present for more than 6 months. So the point here, which is important, for instance, you have an acute illness, and after an acute illness, you experience fatigue for a while, maybe for a week, for a couple of weeks, but usually you get back to the normal self. People with chronic fatigue syndrome, they suffer from a chronic and debilitating fatigue. The second point is debilitating. That means it's a type of fatigue which will cause a lot of impairment. It is persistent, which is almost same as chronic. It is unexplained. So it is not because of an excessive exertion which this person is not used to, but it is mostly unexplained. And it is not relieved by days. More often than not, when a person is fatigued, either physically fatigued or mentally fatigued, when that person takes rest, the fatigue normalizes or resolves, and the person gets back to normal. It does not happen in chronic fatigue syndrome. And it is exacerbated by physical or mental exertions. I have highlighted mental exertions here because physical exertion is a common sense. Every one of you would recognize that. Chronic fatigue syndrome might set in, or the fatigue in chronic fatigue syndrome might set in even after mental exertions, like reading a newspaper, carrying out a conversation on phone. That might be very tiresome for these group of individuals. Now, there are two different names for this chronic fatigue syndrome. This is an older name. The two newer names are myalgic encephalomyelitis and systemic exertion intolerance disease. Now, there is a little bit of history behind those name changes. Chronic fatigue syndrome was initially understood as psychological or a biopsychosocial, completely biopsychosocial disorders. But later on, people realized the biological basis of chronic fatigue syndrome overrides the psychosocial basis of chronic fatigue syndrome. Moreover, people suffering from chronic fatigue syndrome, they do not seem to take this biopsychosocial point of view very sportingly. For them, it's more biological and less psychological and psychosocial. And there is a chronic fatigue syndrome advocacy group. They advocate for the biological origin of chronic fatigue syndrome. Perhaps because of these two reasons, you could see the first name, myalgic encephalomyelitis. So it sounded more like a biological illness. It also incorporates other aspects of chronic fatigue syndrome. For instance, myalgia is a very often associated symptom of chronic fatigue syndrome. So it incorporates that as well. The second one, systemic exertion intolerance disease, again, it changes the concept from syndrome to a disease, like cardiovascular disease. So when you call something as disease, it of course harps on the point that this is a biological disease. So this was proposed by Institute of Medicine in 2015. And nowadays, I guess, this is the most acceptable terminology. or these are the most acceptable terminologies than chronic fatigue syndrome. It also recognize that this is a CFS/ME day now. It was initially a CFS day. Now it has been changed. The name nomenclature has changed. The second set of important points is that it affects two age groups, primarily 10 and 19 and 30 and 40. And you would recognize these two are vital age groups. The first is an academic, is the age group in which people acquire knowledge and they are students primarily. And the second is mainly the productive age group. So it will cause a lot of burden, not only to the individual, but to the society, the chronic fatigue syndrome in general. Because almost 75% of people who suffer from chronic fatigue syndrome, they are unable to work or they work only minimally. And about 25% are bedridden. So that means if somebody suffers from chronic fatigue syndrome, if it remains untreated, then the chances of recovery, it's very low. And finally, there are several other associative symptoms. I have already spoken about pain and the importance of pain in myalgic encephalitis. Dr. Gupta has talked about the problems with relation to sleep and cognitive dysfunction, especially attention span problems related to short-term memory. But there are other problems like autonomic dysfunction, which is manifested as orthostatic intolerance. I will discuss it in my next slide. So as I have mentioned, there is a tug of war between the biological and psychological, but at present, the biological understanding of chronic fatigue syndrome has taken precedence over the psychological understanding, but the psychological understanding did not completely go away because the management to a large extent also depends on a lot of psychotherapeutic interventions. If you consider ICD-11, the chronic fatigue syndrome is within the neurological disease category. It is AT49, which falls into the other neurological disease categories, and it is named as post-viral fatigue syndrome. So ICD-11 almost has given an etiological understanding of chronic fatigue syndrome, that it is supposed to be post-viral, after a viral infection. And it does not include chronic fatigue syndrome under mental health disorders. So again, it emphasizes the biological underpinning or biological nature of chronic fatigue syndrome. Interestingly, post-COVID, there is a resurgence in the interest of chronic fatigue syndrome, which is also reflected by several studies, post-COVID-19, brain fog, etc., which were combined later, and a meta-analysis was done by Salary and colleagues, and they found almost 45% prevalence. The pooled prevalence of chronic fatigue syndrome post-COVID is 45%. Now, the diagnosis of chronic fatigue syndrome, there are various diagnostic criteria, but the most accepted one and the recent one is the Institute of Medicine USA criteria, which was given in 2015. So there are 3 core criteria which must be present to fulfill the diagnosis of chronic fatigue syndrome, and out of the 2 additional criteria, 1 must be present. In the core criteria, the first point is fatigue, as you all know, but along with fatigue, there should be significant impairment. If you recall, my first slide was about debilitating chronic fatigue. So the first criteria actually reflects the debilitating and chronic nature of the fatigue. The second is post-exertional malaise. Again, Dr. Gupta has already spoken about that. Means a little bit of exertion will produce a disproportionate amount of fatigue, a continuous days of not working or bedridden conditions. Post-exertional malaise can be immediate, can also be delayed. Might start like the day after the exertion, might also start a couple of days or even after a few weeks of exertions. So these are important because when you ask your patients, these correlations must be made. The third core criteria is unrefreshing sleep. And out of this additional 2 criteria, cognitive impairment, I have already spoken about it, and orthostatic intolerance. I promise that I will talk about it. This is an additional criteria as per IOM. Orthostatic intolerance means when a person stands or walks, the symptom of fatigue worsens. It might also be associated with other autonomic dysfunctions, like feeling of giddiness, tiredness, etc. There are other set of criteria, as I have mentioned, Canadian consensus criteria, international consensus criteria. So overall, there are certain diagnostic challenges. Again, Dr. Gupta has talked about it. I'm just highlighting these points. First of all, chronic fatigue syndrome is a diagnosis which is clinical and subjective in nature. We do not have any objective tests, for instance, checking the blood pressure or blood sugar to diagnose somebody with. So we do not have any biomarker as such. It's mostly a diagnosis of exclusion. Although the IOM criteria wanted to do away with the diagnosis of exclusion and given a specific set of code and additional criteria, but he would recognize that a patient with fatigue and chronic fatigue, you always would look for other physical and medical mental health conditions. And there is no definite set of consensus criteria. So there are, as I have mentioned, there are multiple set of Canadian criteria, international consensus, the IOM criteria. So, and ICD-11 does not mention any criteria in their website. So there is a lot of chance of underdiagnosis and misdiagnosis. In fact, there is a US survey which showed that almost 90% patients of chronic fatigue syndrome were not diagnosed by their GPs. So it's an underdiagnosed condition. However, we would see if you see the diagnostic features of CFS as per IOM, you would see a lot of overlap with other mental health disorder diagnoses. For instance, take example of fatigue. Fatigue is very common in major depressive disorder. In fact, fatigue is one of the core criteria for major depressive disorder as well. Post-exertional malaise, again, can be seen in patients with major depressive disorder, anxiety disorder, or somatoform disorder or bodily distress disorders. In fact, a lot of patients with chronic fatigue syndrome, if they seek treatment to a psychiatrist, many of them would be diagnosed with somatoform disorder because of the overlapping symptoms. Unrefreshing sleep, again, this cuts across many psychiatric and mental health disorder. Likewise, cognitive impairment are also common in major depressive disorder, like attention span problem, short-term memory. If you see patients with depression, they will complain that they frequently forget about where they have left their keys, or frequently forget to add sometimes salt to the food when they're cooking. So those are complaints you will also see in various mental health disorders. So what I wanted to highlight with this slide is that there is a lot of overlapping symptoms between mental health conditions and myalgic encephalomyelitis or chronic fatigue syndrome. Interestingly, the comorbidities between these two disorders are very high. For instance, if you take any mental health comorbidity, which has seen almost 80% patients with chronic fatigue syndrome, almost 1/3 of them might be suffering from major depressive disorders. Again, almost 1/3 might have anxiety disorders. And a substantial proportion will also have somatic symptom disorder or bodily distress disorders. So what does this all mean? Although chronic fatigue syndrome is not a mental health disorders, as ICD-11 has made it abundantly clear by including chronic fatigue syndrome not under the mental health disorder category, but in the neurological disorder category. However, one must screen for other mental disorders. If you find a patient with chronic fatigue syndrome, diagnose that patient with the core set of criteria given by IOM. You should also look for mental health disorders, like I mentioned, anxiety, depression, and somatoform disorders. And if they are present, they must be treated independently. Now, how could you explain this association? One way of explaining is that there could be a common underlying etiology. However, whatever the reason for association is, mental health disorder and a chronic fatigue syndrome, they might exacerbate each other's symptoms and increase the burden of care and burden of the disease. Generally, there is a biopsychosocial model which is accepted, which has been accepted at one point in time, very widely accepted for the origin of chronic fatigue syndrome. So these are the biological factor. They say there is a problem in energy metabolism, neuroimmune dysregulation, neuroendocrine dysregulation, etc. However, they also talk about a lot of psychological underpinnings. For instance, patients with chronic fatigue syndrome, they are more likely to experience stress. So this is known as stress sensitivity. Say you have given a task, you have been assigned a task for the same, and your friend have also been assigned the same task. You and your friend might experience different level of stress for the same task. Now, this is known as stress sensitivity. Some people are more vulnerable or prone to experience stress than others. So those who are more vulnerable to experience stress, they are more likely to experience chronic fatigue. So this was one of the understanding. The second is catastrophic thinking. Catastrophic thinking means the way we perceive our world or the way we explain things that is happening to us. Take example of a patient with chronic fatigue syndrome. When there is a fatigue, catastrophic thinking is an example of catastrophic thinking could be, well, I am fatigued. That means I might have cancer. I might die soon. So catastrophic thinking is something which is extreme. A one day of fatigue, a person might think that he might die soon, or he might be having a very serious illness. So you could imagine when a person thinks that way, the likelihood of feeling fatigue will increase further, and this will again form a vicious circle. Finally, there is a tendency towards negative emotional experience. So generally, these people are more dysphoric, more agitated, angry, sad, and anxious. There is a tendency towards negative emotion. Therefore, whenever there is a trigger, there is an abundance of negative emotion. And this negative emotion starts the feed-forward cycle for the fatigue, and again, it sets in a vicious cycle. Finally, there is a social model that there is a structural stigma against these people with chronic fatigue syndrome that they have complained about, that the GPs do not take care of them, they do not accept them as their patient. They generally prefer to refer them to a psychiatrist, where they otherwise would not go. They tell something like, these symptoms are all in your head, they do not exist already. So these are all examples of structural stigma, and that actually worsens the symptoms of chronic fatigue syndrome. And there is work loss and productivity, and because of that, there's a lot of criticism from the family and others, and therefore it might also exacerbate the symptoms of chronic fatigue syndrome. So this is kind of the biopsychosocial understanding that there is a biological basis, but the psychological and social factors kind of influence the biological factors to exacerbate the symptoms or make it difficult to treat these individuals. Dr. Gupta has already talked about it, the relationship between chronic fatigue syndrome and substance use. So I am going to skip this slide. Now, there is a concept of penal phases of chronic fatigue syndrome. So it seems people who suffer from chronic fatigue syndrome, you can categorize them into phases if you observe them longitudinally. Overall, if you look into the longitudinal or prospective studies on patients with chronic fatigue syndrome, only very few, only about 5% of them recover completely. 95% of them would have some symptoms. Out of that, almost 25% would have severe symptoms or debilitating conditions, and they would be bedridden because of that. However, there is another section which would suffer from mild to moderate chronic fatigue syndrome, and this penal phase is mostly applicable for these category of patients, which is the major category of patients with chronic fatigue syndrome. The first phase is the phase of crisis, in which the acute symptom happens. The patient is completely bedridden. They cannot do anything. They cannot make any sense out of it, that what is happening to them. So therefore, there is a lot of emotional turmoil that something bad might going to happen. I might have been suffering from very serious illness, etc. The second is the phase of stabilization, when the understanding of chronic fatigue syndrome just sets in, that yes, I might have a condition which is known by chronic fatigue syndrome, which might have a biological basis, but this understanding is not complete, it's just setting in. The patient is just starting to get out of the bed and, try and explore a little bit of activities, but not functional at this stage. And there is still a lot of emotional turmoil happening during the stabilization. The phase of resolution. Don't mistake it as resolution of chronic fatigue syndrome. No, this is basically resolution of the conflict that is going inside the mind, that what I have been suffering. Now, almost there is an understanding that I am suffering from a condition, chronic fatigue syndrome, and finally, the stage of integration, when they believe that it is a condition which is unlikely to recover completely, so I should concentrate on my quality of life and functionality. Why is this important? Because at various stages, you have various interventions, psycho-behavioral interventions. For instance, when there is a crisis phase, empathy and providing support, not only by the doctor, but also the family is important. The crisis phase. The stabilization phase, providing information, conducting dialogue, that what is chronic fatigue syndrome, what are the etiological basis of chronic fatigue syndrome, how it can be treated, what are the generally longitudinal course and outcome of chronic fatigue syndrome, and start a little bit about what is known as adaptive pacing therapy. Adaptive pacing therapy is basically the patient themselves, they create their own routine and they gradually engage and involve in activities, very small activities, and they revert back if there is an increased exertion. So it's a patient-centered, you can say, exercise therapy. And also you can start a little bit of cognitive behavior therapy in the resolution phase, when there is an understanding of chronic fatigue syndrome and the biopsychosocial nature of the chronic fatigue syndrome. Finally, at the integration stage, when the person is almost certain that recovery might be impossible, one can go with cognitive behavior therapy. There is a lot of talk about graded exercise therapy. This was treatment which was recommended at one point in time, but now neither CDC or the NICE guideline of the UK, they recommend graded exercise therapy because it might cause more harm than good. Medications, there are no approved medications for the treatment of CFS, but there are symptomatic treatment. For instance, somebody is in crisis phase, you might like to give them analgesic if they are pain. If somebody is depressed and anxious, you should treat them with anti-anxiety or antidepressant medications. So treatment of comorbidities. And there are also treatment of putative causes. Again, anti-inflammatory like rituximab, etc. have been tried, but they with no significant results. There are no approved treatment. So here are my final slide. Here is my final slide, the take-home points. The comprehensive assessment is required for the diagnosis of chronic fatigue syndrome, because you need to rule out many other physical and mental health comorbidities, or need to take into account those comorbidities in fact. And always remember post exertional malaise, which is one of the very core criteria of chronic fatigue syndrome, does not happen in many other disorders. Prioritize symptom control and patient education. Take an empathetic and supportive stance rather than contradicting the patient, telling the patient all is in your head. Avoid misdiagnosis. So misdiagnosis, chronic fatigue syndrome is a mental health condition or other physical comorbidities, and stigmatization as well. Address other mental health and substance use comorbidities. Treat them adequately when they are present. Treat the tobacco cessation if that is present. Take help from professional colleagues and patient's family. Finally, if you feel that you are being exhausted, you have exhausted all your options. These are the references, and thank you very much. I'll stop.
Thank you, Dr. Abhishek, for a very informative presentation. And I think you have put CFS in a center stage. At least now all the health workers they would after we'll be sharing this recording also. So most people will now know what is CFS and how to diagnose it, and the diagnosis should not be missed. And it is treatable condition also. So Dr. Abhishek, he told about the chronic fatigue syndrome and the psychosocial underpinnings of CFS, and what is the relationship between CFS and mental health disorders. What are the psycho-behavioral interventions for CFS? So he very nicely explained everything, and the presentation was very good. So Dr. Abhishek will like you to stay with us for some time, so that if there are any questions, you can ask them. So thank you. So now we have with us Dr. Suneela Garg. So Dr. Suneela Garg is Director, Professor, HAG Community Medicine, ex-head FMS, CM, MAMC, that is Maulana Azad Medical College, and she is Subdean of the Maulana Azad Medical College and Associated Hospitals, New Delhi, India. And her present designation is Professor of Excellence, and she is Chair of the Program Advisory Committee, NHFW. And she is member DHR, professional and research experience of 43 years. So that is quite a lot. And she is member and subject expert of the CDS CEO and national president of IAP SM 2122. So over to Dr. Suneela Garg. Will just like to know about the public health implications of CFS summer. So thank you.
Thank you, Dr. Rakesh, first of all, for putting importance on this topic of chronic fatigue syndrome, which many of us have been, kind of ignoring it and putting it into the center stage. And thank you, Dr. Rakesh Gupta, also, basically, who highlighted, the importance of nicotine. And all my blessings and congratulations to Dr. Abhishek for making it a very interesting and very important topic. Because we know when we look at a disease, which is, so very common when you talked about mental health disorders and to the, the relation to the tune of, 80% and the relation to the tune of 33% with the anxiety and all that. So it's a very major public health problem, because as it is, when we look in, global context and when we look in Indian context, basically when we look in Indian context and we look in global context, different studies are there which have pointed out the prevalence from 0.007% to 2.8%, which I feel is a gross underestimate. Though in global settings, they've also said that it is about, overall community prevalence is about 1%. But in India, there was a study in early 2000s which pointed out that in women, it varies to, it's to the tune of about 12%, I'll say, which again, I'll say is a high number because, and also, but it is still an underestimate, because I feel that large proportion of women, they do not report to the healthcare facilities. So that is important part, and we do not have a study. So one of the important public health perspectives is that we do need a rigorous study which is focusing on this direction. So, basically, as it has been pointed out earlier also, that there are two spurts. One is around 11 years when it is manifesting, and second is about, 30 years of age. But by the time, when we look at our Indian population, which is 140 crores with lot of regional and systemic differences, the people are not reporting to the healthcare facilities because they think, they tend to suffer from these symptoms. So ignorance at large, prevails over the diagnosis of chronic fatigue syndrome, or which is also, was mentioned by Dr. Abhishek as meningoencephalomyelitis or systemic, exertion intolerance. This is another important part, which is important. Another important thing from a public health perspective is that it is prevalent more in, population in poor socioeconomic status. So definitely, ignorance and healthcare seeking is also poor. So people tend to, kind of suffer from the disease. And that is where, when Dr. Rakesh was pointing out, it is important, particularly to sensitize our 3 A's, that is Ashas, Anganwadi workers, and ANMs, when they go to the communities to look at this, ask and do not ignore. That is important part which we have to look at. So this part is important. And another thing which has been highlighted also, and which I have observed very closely after working with long-term implications of COVID. Now we are seeing many cases of chronic fatigue syndrome, and particularly also these are more common in women. So that part is very, very important. Another thing is that when we look at what are the risk factors, so few of the risk factors has very, clearly emerged in terms of, the gender part, as you age, and another part is that the socioeconomic factors and minority groups, that is cultural and ethnic groups, they have, higher rates of chronic fatigue syndrome. But important part which overarches all of these is lack of awareness. Because you see, we attribute mostly to anemia because 56% of our women are anemic and nearly about, between 16 to 18% of our men are anemic. So that is where, if you look at the total population, it is nearly about 70% of our population suffers from anemia. So quite a number of times we attribute it to that, but it is not the single factor which is responsible for chronic fatigue syndrome. So that is where, so only nutritional deficiencies are not responsible, but there are psychosocial factors when we look at, poor mental health and also, gender disadvantages, which are strongly associated with chronic fatigue syndrome. And also we know that infections, stress can also trigger the chronic fatigue syndrome, which is very, very important. So but most important part, which I'm highlighting again and again, is we do have a very limited data. So the important part is of the research part, which we need to, the research has to be undertaken more into this direction, and particularly community-based research. Because before we started the webinar, and I was talking to both Dr. Rakesh Gupta and Dr. Abhishek, that we need to have a rigorous research in this direction, because diagnosing CFS per se or chronic fatigue syndrome is challenging. It is pursued, by exclusion. So that part becomes very, very important. And living with chronic fatigue syndrome is also very, very challenging. So you see, when we look at the public health implications, few immediately I like to point out that there is reduced health-related quality of life, which when we measure it by WHO scale, breath questionnaire and all that, so chronic fatigue syndrome is going to significantly lower the quality of life as compared to other chronic conditions, even when we compare with cancer or rheumatoid arthritis, that is, and impacts our daily activities, which is very important. It limits our social interactions and also enjoyment of life, number one. Number two is that there is increased disability, so which is leading to significant functional, impairment. And some patients are unable to work and even leave their homes due to severity of the symptoms. And another important thing is that it leads to increased socioeconomic burden, because we know that there is substantial increase, because of, person is not able to work. So there is loss of productivity also and disability related expenses. And there is also impact on, when he said, Dr. Abhishek, that there's academic impact. So it impacts on work as well as education. So that is where people are not able to complete their educational programs, and also there is increased fatigue and cognitive impairment as well. So, and also we know that this world is of survival of fittest. So that person tends to get socially isolated as well. So that is another important part. And there is also increased expenditure because of healthcare utilization. And both, when we say that we must reduce out-of-pocket expenditure, sometimes it is not possible also, because every time the person will go to government facility, not satisfied, he or she tends to go to private facility. But important part, in our context, in Indian context, is if you look at all the records and registers and all that, women are much more, underrepresented, because healthcare seeking is comparatively less. When we look at different parts, we have got 36 states and union territories. So that part becomes very important. And another part is that when we talk of, mental health issues, so depression and anxiety is quite very common in these individuals. So that is where there is increased need for awareness and education at all levels. When we talk of policy level, program level, or at academic level, or at community level, when I talked of three fronts, or at systems level. So our providers, both in government and public sector, need to be educated more and more. And important, the challenging part is that there is no cure. So when we talk of, how the person has got to be managed, and as you would listen to or recap what was Dr. Abhishek's presentation, so primarily, he mentioned on, activity management, that means spacing of activity, gradually, increasing the exertion and all. But also we need to avoid those activities which are going to trigger the chronic fatigue syndrome. But there are mostly approaches which are non-pharmacological in nature. So that means we are talking of deep breathing exercises, bringing change in our lifestyle, muscle relaxation exercises, massage, acupuncture, and cognitive behavioral therapy, which can lead to, which can be helpful. So as I said that there is no cure, so we need to move from, illness to health to wellness gradually. So lifestyle modifications are ones which are, basically focusing on managing the symptoms or improving overall well-being. That is important. So that means we have to focus on good sleep hygiene. Number 2 is practicing, activity spacing and adopting a balanced diet. That part is also very, very important, because when we look at our fast foods and our style of living, that needs to have a vigorous address as well. And another part is that additionally, we need to manage the stress, and considering professional guidelines. We need not consider it at sigma. So awareness in the population is got to be that professional guidance needs to be sought. And these are important aspects of living with chronic fatigue syndrome. And also, when we look at some of the pharmacological approaches, this will focus on antidepressants and all that. That means allaying anxiety disorders. So basically, it has got to be more symptomatic in nature. And I'll say there is a lot of role of counseling, because when we look at viral disorders like COVID, and when we thought of establishing post-COVID clinics, that was mainly focusing on not only managing the symptoms, but allaying anxiety and disorders, which will come through proper counseling. So that part becomes very important. So it is not one discipline. It is, we need to have a multidisciplinary approach. When we talked about, tobacco cessation, when we talked about, role of psychiatrists, physicians, even, when the problem is more, in females, so there's a lot of role of, our 3 A's, and plus female medical officers, ops gynae. So, we need to have plus overarching public health professionals, because when it is, most of the people are not reporting, so that becomes a very, very important issue. Another important thing from a public health point is that we need to take a strong research. Our research development has got to focus, because you see, research data is very, very limited in this direction. So, and the diagnosis is by exclusion. So we need to focus, and we need to make it as there are 12 task forces at the comprehensive primary healthcare level, out of which mental health is also one of these. But we need to look comprehensively at mental health. We need to look at anemias. We need to look at chronic diseases. So we need to understand more about what is the cause, how can we diagnose and treat the condition. Another important thing is that number 1 is we need to have a multidisciplinary approach, improve access to healthcare. That is important. And do not neglect or do not blame the person if he or she is repeatedly coming with these symptoms. That part is important. Again, important part is our school health authorities, because this is also affecting the academic activities. So sensitization of our school health authorities, teachers, is very, very important. So we need to have, multidisciplinary team at the school level as well. We need to have adequate support systems for diagnosing and managing the individuals with chronic fatigue syndrome, including peer support groups. You see, no one is better than our peer group, and they need to understand, particularly in context of school, or because it's a fairly, you will realize, younger population. And when we talk particularly of women, when they have to look at home front, they have to look at professional front. And these days in the competitive society, so we need to create more and more awareness as well. But important part, Dr. Rakesh, through your seminar, I'll say that there is a lot of need for policy and advocacy. So that is where we need to, focus at the policy level, and we advocate more and more at all levels of systems, so as to focus on the individuals with chronic fatigue syndrome, including, increasing their access to disability benefits. So they need to get the disability benefit as well, and reasonable accommodations which are, user friendly, and improved, healthcare coverage. That part becomes very important because sometimes, when we look at, the person is isolated and, this can be a common, issue which is leading towards, end of life or suicides. So that part also needs to be addressed as well. So with this, my dear friends, I like to see focus on this very, very important issue, which should not be neglected, which is much under researched. And we do have but important part is that we do have a global, chronic fatigue day syndrome. That is why we are talking, basically at this forum. So that part, so I'll really, congratulate Dr. Rakesh for having this very, very important webinar. And I can see a lot of people who are present in the audience, and each one of you is a messenger of change. Please carry this message forward and see how all of us can make a difference. Thank you so much. Thank you.
So thank you, Dr. Suneela, for highlighting these public health perspectives for diagnosis and management of the chronic fatigue syndrome. And it is very important that 12%, it is 12% in women, and they are not reporting to the health facilities. And we must have a very rigorous studies regarding the chronic fatigue syndrome, especially in the females. Then it is related to the poor socioeconomic status and the risk factors of the gender, age, lack of awareness. And as you told, that 70% of the population are anemic. So it may be considered that it is because of the anemia, but the factors may be many in addition to the anemia. So thanks a lot. And I think you'll stay with us for answering the questions. And I may acknowledge the presence of Dr. Siddhi Hathiwala and Mrs. Sneelata, who is a teacher at Center School. So they are also present. So I'd like to have their remarks from Dr. Siddhi Hathiwala. And Rajeev, you may just have a look at the questions in the chat box. So Dr. Siddhi Hathiwala, yeah. And and Mrs. Sneelata, are they with us? Okay, you may just carry on.
Okay.
So Siddhi Hathiwala, she says that I'm in department clinic and listening to the webinar also. So thanks for joining here.
So thank you, Dr. Rakesh Gupta, sir. So now, I think Ma'am Siddhi is mentioned, can't speak. Okay. So in case of any questions related to the presentations and the topic, I request the participants to unmute yourself and ask your question to directly the experts. We have expert with us. So
Good afternoon. Good afternoon, sir. I'm Sneelata.
Yeah.
Yes. Please go ahead. Yeah.
Thanks for joining. So your remarks on the presentation.
Sir, I joined 10-15 minutes late, but whatever I watched, it was very beneficial. Lot of information I got it through this session related to the diseases, how to take care, and all the different aspects were covered very nicely by all the speakers. And I feel if some awareness programs are launched at the school level or college level, I think it will be beneficial for the students also. Because when we go and tell our principal that we attended the session, she appreciates that. But I think once in a year also, if it is done at the school level, I think it will be very beneficial for the students, especially for classes 8 to 12th. So I'll be grateful in case you are able to organize something for the school level.
Oh, yes, anytime. So now World No Tobacco Day is coming, yeah. So you must.
So there's a very, very important question, that it is the lack of awareness, which is there, and quite a number of times we tend to ignore. And it is also in a batch of 38 or 39 students, we'll only focus on, the better performing and the mid-level performing, but these children are left out. So sensitization of principals, teachers, and everyone. And through them, the parents is also very important, because there is no need that, it should affect the academic performance, because these children will need lot of support from their peers as well as from the teachers. So school environment also has a lot of difference, Dr. Rakesh. I feel that, and you really pointed out, and I came in between that, there is World No Tobacco Day coming when you'll be addressing school. So this can be also one of the important agenda. Right. Thank you.
I
Thank
can
you.
tell you, Dr. Suneela, Mrs. Snehlata, she's
Yes,
a
sir.
teacher. She's a very senior teacher in St. Anne's School. It is in Sector 32.
Very nice. Yeah.
And she has
So
been,
it comes.
and she has been teacher for my kids also.
Yeah, sir.
Very
This year
Yeah.
I'm going to retire.
Oh, that is great.
But
You're not. No, you're going to only retire, but you're not tired.
no,
You're
no,
not
no.
tired.
Yes. Of course. I might join sir's webinars and all slowly.
Yeah. You must.
Yeah. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Shinelata. Sir, we'll ask the participants to unmute yourself and ask your questions. Sir, I have one question to Dr. Abhishek, sir. So,
Yeah.
Abhishek, sir, which age group is more sensitive to this particular chronic fatigue syndrome? So, is there any precautions they need to take? Yeah, it is for everyone. Yeah, according to you.
So basically, there are two definite age groups or age peaks, you can say, for chronic fatigue syndrome. One is between the age of 10 and 19 years. That's basically the school-going children and adolescents, school-going children and adolescents age group. So the advice or the suggestions are having an awareness program of teachers, principals, parents is very much welcome. And the other age group is 30 and 40 years. So the productive age group, people who are at their prime of their age, working somewhere. So these are the two age groups. And about genders, it's 3 times more common in women than in men. So so women are more vulnerable. And especially in the Indian studies that was done in Goa, they found that it was not only common in women, but also women who are relatively less educated, coming from a socially deprived background, or who are minorities. So again, I think Madam has already spoken about it. So it's more common in those who are socially marginalized.
Yeah.
So the problem is also this will cause further marginalization. So it's a kind of, again, a vicious cycle will set in.
Okay. So thank you, sir. Thank you for highlighting these two
And
age
Rajeev, I
groups.
think if there are not many questions, we can ask for the concluding remarks from the presenters.
Yes, sir. So one message in chat I have seen that Dr. Shreya Dwivedi mentioned that many time people know that adverse effect of tobacco and even want to quit it completely, but they are unable to quit. So how to keep motivated every time and convince them to completely quit tobacco consumption, especially for young people who find it cool to smoke. So maybe I can ask Dr. Rakesh Gupta, sir, for this question.
Yeah. So, Dr. Rakesh Gupta, are you with us?
Yes, sir, is here with us. Sir, you are muted, sir. Can you unmute, sir?
Please repeat the question again.
Yeah. Sir, it is in chat. Like, sir, many time people know the adverse effect of tobacco and even want to quit it completely, but they are unable to
Yeah.
quit. And so, how they keep them motivated every time and convince them to completely quit tobacco consumption, especially for young people who find it cool to smoke.
It is for the motivation of the self. I think one has to understand that tobacco is toxic. Tobacco kills. Tobacco kills half of its lifetime users, and it's the major risk factor for non-communicable diseases world over. Also, one has to know that it affects not only physically, but it also affects us psychologically, socially, economically, environmentally. So in a way, it affects our entire quality of life. And I would say that, yes, for getting more motivation, you should meet the people who have quitted or visit to get negatively affected, I would say, to a cancer hospital, but positively influenced by visiting the tobacco cessation clinics nearby and talk to the in charges there as to what are the benefits of quitting. And I think self-education definitely, now there's a lot of material which is available, so it can help. For the people who are in the younger age group, we do not have as such specific material which can sort of motivate them to quit. But yes, I do understand that the peers play a very important role in the life of the students. So that is one group. I think we are lucky that we have a tobacco-free educational institution program, which is supposed to provide the activities and awareness to the children who are working and who are in the schools through their teachers and the activities which they perform on a monthly basis. We also have maybe the public health people, the people who are working in tobacco control, they may be the resource for these institutions. And I think a lot of engagement of the youth perhaps will help as to how they can be motivated. I certainly feel that the benefits of quitting requires to be promoted more through our IEC efforts countrywide. So these are some of the thoughts which I have to assist the people in quitting tobacco. Over to you, Rajeev.
Thank you. Thank you, sir. I hope Dr. Shreya Dwivedi will get response properly.
Abhishek can add to it, maybe, I suppose.
Yes,
Dr. Abhishek.
I agree with you completely. That it's a motivation is a very dynamic process, so it comes and goes. So it's very important to keep motivating a person again and again. Whenever a person visits a doctor, it's very important to talk about tobacco. And as you said, that if there is a support from others who have already quitted tobacco, or in the school especially, support from the peer educators, those are very useful. Well, in addition to all this, if somebody fails to remain tobacco free even after counseling or repeated instances of counseling, there are medical treatment available. For instance, nicotine replacement therapy, bupropion and varenicline. These are approved treatment for tobacco cessation. Those can also be prescribed.
Thank you, sir. Thank you. So I think there is no more questions, sir.
So you can ask for just a minute concluding remarks from all the presenters, and then we can.
Okay, so we'll start with the Dr. Abhishek sir first. The last comment to the audience on the theme of today's webinar. So over to Dr. Abhishek sir.
I did not get your. I am supposed.
Concluding
remarks.
remarks.
Yeah, sir. Closing remarks, sir. Yes,
closing
sir.
remarks.
Yes,
okay.
sir.
And I was not prepared for it, but I guess this was definitely an excellent webinar for me, because in the first place, I have been practicing psychiatry for the last 15 years almost. I joined as a junior resident in 2009 in PGI, so more than 15 years. I would say now in retrospect, I think I have diagnosed many of the patients with chronic fatigue syndrome, or quote unquote, might have been diagnosed them with somatoform disorders and treated them as such. So this was an educative session for me, if not anyone else, that I can say that, I have learned myself a lot of things during the webinar. And then I have learned a lot of things from Dr. Rakesh Gupta and Professor Suneela Garg, especially the relationship with tobacco and also the importance of taking the public health into account. It's not only the clinical practice, because when there is no awareness, if we don't do that, the patient will not reach to us. So I think that we are at the stage when we need more public health approach to start with, and then it's followed by, of course, a clinical approach. And we have also noticed a glaring research gap in India. Not only India, but also in other part of the world, but also in India. So I think this is a research area where we can focus. And most importantly, thank you very much to Dr. Gupta, Dr. Rakesh Gupta. Now there are two Dr. Rakesh Guptas, Dr. Rakesh Gupta from Sipher and Rajeev from the RCTC and the ECO for organizing this event, because I didn't know that there is a chronic fatigue syndrome day. So there is a dedicated day, and this program, I guess it's very beneficial for all those who have participated in the program, because without their presence, the program would have been futile. So finally, huge thank you to those who have.
And Dr. Abhishek, it is very interesting to know that till the end, actually, more than 70 people, they are associated with they are participating in the program. And your take-home points, they say it all. So your concluding remarks are your take-home points.
Take-home points. First take-home point, I would say that those of you who are doing clinical practice, maybe at the community level as a frontline worker, frontline health workers, or at the clinic level, whenever you see a patient who complains of tiredness, always explore about chronic fatigue syndrome, because now we have a definite set of diagnostic criteria. You apply those diagnostic criteria and see whether they meet the diagnosis of chronic fatigue syndrome. When you diagnose somebody with chronic fatigue syndrome after applying the criteria, always look for other physical and mental health comorbidities, because they are often comorbid with anemia, other mental health conditions. So always look for that. When you have diagnosed both chronic fatigue syndrome and other mental health and physical health comorbidities, treat them with empathy and compassion. Treat them symptomatically and also apply psychobehavioral approach, depending on the stage in which they are in chronic fatigue syndrome. So this is for the practitioners or the clinicians, and for those who are public health expert and researchers, I guess there is a glaring research gap. So one should conduct epidemiological studies and surveys to find the actual prevalence and the risk factors in the Indian population. And then the treatment, the Indianized treatment, I always believe that CBT is a Western form of treatment. It should be Indianized and adopted, culturally adopted form of treatment for chronic fatigue syndrome. So this is the research part, and building awareness among all the important stakeholders. So there is a reduction in the stigma, and there is an increased healthcare seeking behavior. These are
Thank you. Yeah. Thank you, Dr. Abhishek, sir. So now over to Professor Suneela Garg, ma'am, for closing remarks.
Thank you so much, Dr. Rajeev, and to all the participants who are present. I will say that each one of you has an important role to play, because we are all advocates. So policy level and, at the community level, at the systems level, there is a lot of need for advocacy. Even when we were talking to Dr. Suneela, even informing our school health system is also very, very important, because we tend to ignore that child, कि वो बहाने बना रहे हैं या वो worker काम नहीं कर रहा, वो बहाने बना रहे हैं. So in actuality, this is a problem that is important. But as of now, which the message is that we do not have a definitive treatment. So, we have to think from illness to health to wellness. So we have to modify our lifestyle accordingly. So that part is very important. So in this, when we talk of role of yoga, meditation, sleep hygiene, and a graded activity, it's not that the child does not want to go for PT exercise and all that, but in reality, he or she may be fatigued. So that part is very important. Another thing is that if the person is really into anxiety or depression, we need to treat with that. But remember that we have to have a multidisciplinary approach. No one system can address this. And we need to look at even the alternative system of medicine also, which may have answers, or the integrative system of medicine. And there is a lot of role of research and development, I'll say. And this is fairly under-researched area. We have hardly one publication from this part of the region. So we need to go more and more in depth. All the very best. And I think we need to have much more seminars in this direction, Dr. Rakesh and our team, so that we can, kind of explore this possibility that how we can address this issue. Thank you. Thank you so much.
Thank you, ma'am. Thank you. So over to Dr. Rakesh Gupta from Jaipur, Rajasthan Cancer Foundation for closing remarks.
Thank you, Rajeev, and my gratitude to Dr. Rakesh ji for holding the webinar on this very useful topic. I think it's a kind of new information even to us who are working in tobacco control. So I will endorse what has been said already by Dr. Suneela ji and Dr. Abhishek. My only addition could be that, yes, we need to stay aware so that we can talk more about it, create an awareness when we are doing the awareness lectures. And we should also be doing its advocacy so that in the tobacco suggestion delivery through the TCCs, which are being run by the government, the people who are coming with the chronic fatigue syndrome manifestations, they are diagnosed early and managed appropriately. And I consider establishing SOPs can help in this direction as to how we could do. I consider Dr. Abhishek Ghosh is the best person to perhaps give us the outline or structure, and then we can work on it through our tobacco control community. So have included it in the recommendation that Sipher can send to the ministry. That will be perhaps very useful. So I thank you all once again, all the faculty members and the participants. Thanks a lot.
Thank you
for enriching us.
So Rajeev, I think we can conclude
Yes,
10 minutes early, and you can just proceed with the formal vote of thanks.
Thank you, sir. Thank you, sir. So on behalf of organizing team, I sincerely thanks to all esteemed speakers and participants for joining us today on this special occasion. First of all, Dr. Rakesh Gupta, President Rajasthan Cancer Foundation, for his insightful session on the theme and its correlation with the tobacco use. Again, special thanks to Dr. Abhishek Ghosh, additional professor at PGI Chandigarh, for his excellent talk on the psychological aspects of chronic fatigue syndrome. Thank you, Dr. Abhishek, sir. And we truly grateful to have Dr. Suneela Garg, ma'am, a leading public health expert, for sharing her important perspective on the theme as a public health issues. So thank you, Dr. Suneela Garg, ma'am, for your presentations today. And again, thanks to Dr. Rakesh Gupta, President Sipher, for his contribution in organizing this important uh, webinar on this particular theme, and also guiding our team to organize such event in future. Thank you, sir. And finally, thanks to all attendees for your active participation. So let's continue to raise awareness and support those affected with the chronic fatigue syndrome. Thank you, everyone, and have a nice day.
Thank you all. Thank you.
Thank you, sir.
Thank you.
Thank you.